coronary artery disease is the major complication of the diabetes, the most important killer in type 2 diabetes. Over 50% of the individuals with diabetes die due to the CAD. Diabetes and coronary artery disease share a common soil for the development of the disease. So common risk factors and possibly common pathogenic mechanism. CAD, which leads to the premature myocardial infarction, is the leading cause of the death among the people with the diabetes and results in threefold higher mortality than in those without the diabetes. See, this is an important slide. Diabetes has been traditionally considered a coronary risk equivalent. So you concentrate on these two slides, two things, two charts. See, the first one, patient without diabetes and prior MI. So this one, they are not the diabetics. Okay, but the small group, no myocardial infarction, and the green one is the myocardial infarction, but no diabetes. Okay, and then see the second one. Here they are the diabetics, both are the diabetics. The first one without the myocardial infarction, the second one is with the myocardial infarction. Now you please concentrate on this green one and then orange one. Okay, so here the green one is no diabetes but myocardial infarction. Okay, that orange one is, what is that? Diabetes but no myocardial infarction. But here what is the risk here? 19. What is the risk there? 20. So this fellow, the first one, green one, is discharged from the Apollo hospitals with a diagnosis of myocardial infarction but no diabetes. And the second one, orange one, discharged from my hospital as a diagnosis of diabetes but no myocardial infarction. Which one is more dangerous? So the presence of the diabetes itself is more dangerous than the fellow who had a myocardial infarction, because the diabetes will kill you with myocardial infarction, with nephropathy, with retinopathy, etc. and etc. Okay, so that is the reason. Suppose if the diabetic also had a myocardial infarction, so last one, green one, see the risk. So 45. So don't underestimate that the diagnosis of the diabetes is a very a small disease. So the presence of the diabetes itself is as big as a presence of myocardial infarction. A fellow with PTCA or post CABG is also equivalent as a fellow with a diabetes. Suppose if the fellow is also having the myocardial infarction along with the diabetes, then the risk will be very high. So the take home point from this slide is that, so don't underestimate the diagnosis of the diabetes. So the diabetes is as worst as the presence of myocardial infarction. So that is the reason diabetes is considered as a coronary risk equivalent. So you should spend some time with all the diabetic individuals. See what about the carbohydrate metabolism, what is the role of the protein, what is the role of the fat, what is the role of your water, what is the role of your fruits, what is the role of your vegetables, what is the role of your sleep, physical activity. So these are all things you should tell to these patients. Otherwise, these diabetes people will have a lot of the complications in the near future. Okay. See, that is the reason individuals with MI but without prior MI had equal risk of dying from the MI as people without diabetes and with a prior MI. Is diabetes really a coronary risk equivalent? Recent evidence indicate that CAD risk in type 2 diabetes is not universally similar to the risk of the patients with the prior vascular disease, but is highly heterogeneous. Currently, the ACC, AHA guidelines, the ADA standards of diabetes care and European Society of Cardiology guidelines no longer consider diabetes as a coronary risk equivalent. The latest guidelines now recommend the stratification for patients with diabetes when ages are from 40 to 75 years old into different risk categories using a global risk calculator. See the Framingham risk score and CRIS and ethics, they have the different risk scores are there, but Asian Indians may underestimate the true risk of CVD in this population. So we are different. So these are all the risk scores, Framingham score, AHA risk score, UK risk score, etc. So the factors underlying the accelerated heterogenesis in the diabetes. See, you have the three things here. So one side there is heterogenesis. In the center you will have the atherosclerosis progression, and finally you have the atherothrombosis. So if you see the vessels there, see the vascular layers. So they finally the vessel you will have the fibrin cap, and there will be the thrombus, and then the platelets, unstable plaque. So that's how the myocardial infarction or CVA or peripheral vascular disease occurs. So these are all the different mechanisms. See, I told you that nitric oxide is important, that will be reduced, and I told you that free fatty acids should not be there. So increase the free fatty acids, increase advanced glycation and products, increase PKC or increase polypoil pathway, increase inflammation, increase vascular inflammation, especially rise sensitive CRPs. So increase react to oxygen species, proliferation, migration, mitochondrial dysfunction, epigenetic modifications. So these are the underground mechanisms. All these mechanisms are in the presence of hyperglycemia. So the more the blood pressure, so all these mechanisms will occur. And finally, what will happen to the vessels? So there will be the fibrous cap, thrombus, and then the platelet and unstable plaque. See the CAD in the presence of the stable angina. Stable angina, they will have the chest pain for a particular distance. And after that, they will be, without that particular distance, they don't have any angina. That is the stable angina. Unstable angina is usually because of the instability of that plaque. So this is as worst as the myocardial infarction. So all the unstable angina population should be screened for your angio, and then if they need PTCR, etc. Variant angina, prinzmetal angina is a very, very rare. That is because of the spasm of the coronary vessels. That is the prinzmetal angina. And of course, acute myocardial infarction can be divided into ST elevated myocardial infarction and non-ST elevated myocardial infarction, and both should be given very importance. So immediately the primary PTCA and then PTCA or CABG according to the single vessel or double vessel, triple vessel. And even if the left main coronary artery is involved, so even with a single vessel, the one should be subjected for the CABG. And in the diabetic, chronic diabetics, and CABG is much more better than the PTCA. So in people with the diabetes, CAD, even the MI could be silent. That is the very, very important in the diabetic individuals. So don't think that all the diabetic individuals with myocardial infarction will have the chest pain. So chest pain will not be there in a chronic diabetic individuals. So what symptom you will have? So other than the chest pain, so that is called angina equivalents, like breathlessness. So breathlessness in a diabetic individuals, you should be aware that it could be because of the myocardial infarction, because the pain maybe is the silent here. So peculiarities in the presentation of the CAD in the diabetics. So the diabetic CAD is different from the non-diabetic CAD. It may be silent, as I told you. So without the chest pain, these people will have that breathlessness. So don't think that this breathlessness is because of the bronchospasm and start giving the Decadron or start giving the Derifilin and you are killing the patient. So in uncontrolled diabetic individuals, when the patient is complaining of the breathlessness in the absence of the chest pain, so please think of the myocardial infarction only. Get an ECG done, get the troponin or the CPKMB, etc., and act accordingly. At least you observe the patient for 1 hour, 2 hours. Again, take one more ECG, and if both the ECGs are the normal, then you can rule out the ongoing myocardial infarction in this fellow, and then treat accordingly. But my take-home point to all of you is, so don't wait for the chest pain in a chronic diabetic individual. Chest pain may not be there, so it may be the silent. No pain at all. Painless myocardial infarction is very common in a diabetic individual. So what is more common than the chest pain is the breathlessness. Sometimes pain in the jaws, pain in the shoulders, or pain in the scapular region, or pain in the epigastric region. So no pain in the pericardium, in the precardial region, but the pain in the somewhere. So that is also you should think that it could be because of the myocardial infarction. So I have seen some patients with the pain in the jaws, or pain in the mandibles, or pain in the epigastric region. They thought that it is because of the gastritis. One professor of the surgery came to me when I am in the busy in my OP. So he asked, Jawahar, you have Gelusil unda, Pantocid unda, Joffer unda, I am having severe gastritis. And I will see the pulse rate is 130 and he is in the perspiration and the BP is falling down. And then I take an X-ray, ECG, extensive anterior wall infarction. Then we refer to the cardiologist and immediately the primary PTCA was done and it is a triple vessel disease and later shifted to the Hyderabad and then the CABG was done. Now he is alive even after the 15 years right now. Okay. Suppose I have given him the Gelusil or the Pantocid. So imagine the life of him with an extensive myocardial infarction, anterior wall infarction. He is a diabetic. He is a diabetic. See, in all diabetic individuals, so don't think that the pain in the epigastric region, it could be a myocardial infarction also. So in all the diabetic individuals, pain in the epigastric region, pain in the jaws, pain in the shoulders, pain in the scapular regions, get an ECG done. And if even the ECGs are normal, so still think of the myocardial infarction only. Observe the patient for 1 more hour. Take another ECG. And if any changes are there, then act accordingly. If no changes are there, then you can rule out the myocardial infarction. Meanwhile, you get the troponin also. So that will be the positive or the abnormal or normal, you can note that. So in all the diabetic individuals, especially our kith and kin, a diabetic individual, pain somewhere in the chest or in the abdomen or in the face. So don't think that it is non-myocardial infarction. So think as if it is a myocardial infarction and act accordingly. You can give the aspirin, you can give the clopidogrel, you can give the statin, maybe 40 milligrams or 80 milligrams of the atorvastatin or 40 milligrams of the rosuvastatin, even the dispirin, that is more important than the ecosprin. So don't use the entry-coated aspirins here. Use the dispirin, a simple aspirin, okay, about 325 milligrams, and then wait for 1 hour or 2 hours. Nothing will happen if you give the aspirin or the clopidogrel or the statins. So after that, you can discharge the patient whether the diabetes with MI or non-MI. So it occurs at an younger age group. Atypical present, already I told you the angina and equivalence occurs at an younger age group. In all the diabetic individuals, we are seeing my photographer, very good photographer. He is a diabetic at the age of 28 years and at 34 years he presented with the chest pain and acute myocardial infarction and 1 PTCA and right coronary artery. At the 38 years, again he got the severe myocardial infarction second time and again another PTCA. Now he is about 44 years. Last year only underwent CABG. Imagine. Very quite a good number of the people are having the PTCAs or the CABGs even at the age of 40 plus or maybe the 45 plus in Indian population. So the myocardial infarction or PTCA or CABG occurs at an younger age group, especially in our Indian population, especially our South Indians. May involve small vessels selectively, the microvascular angina. Everything is fine. If you see the angio is also normal, but still the patient will have the chest pain. This is microvascular angina. Will not be seen in your angiograms. So angiograms, right coronary artery, left coronary artery, circumflex artery, diagonal arteries, these are all the big vessels. So what about the collaterals? So this is the microvascular angina. Here you need to use the renoxapril or the necorandil or maybe the sorbitrate in a longer duration and then sometimes maybe the diltiazem and again the statins, aspirin, clopidogrel, etc. etc. Okay, but still the patient are having the more and more microvascular angina. So even though the major vessels are the normal, subject for the CABG. Okay, so this is about the microvascular angina. There is a diffuse and the multiple vessel involvement in all the diabetic individuals. So the diffuse disease, it is very difficult to keep 1 or 2 stents in the single vessel. Sometimes now you have to put the 2 or 3 vessels, 3 stents because of the diffuse disease, not a localized one. Entire the vessel is diffusely atherosclerotic and diffusely blocked. So that is the reason in all the diabetic individuals, because of the multiple vessel involvement, because of the diffuse nature, who is subject for the CABG rather than the PTC. Okay. Complications of AMI also very common in the diabetic individuals. A lot of the diabetes and myocardial infarction. So even in the cath labs also, the people with the die on the table, maybe because of the ventricular arrhythmias, ventricular fibrillation, ventricular arrhythmias, so sudden cardiac arrest, okay, or blocks, or complete heart blocks. So these are the very common. So no cardiologist will give the guarantee for the acute myocardial infarction. See, they are doing their level best in doing the angio, in keeping 1 or 2 stents or 3 stents and then keeping in the ICU, but there is no guarantee that this fellow will go to the house. So what happened last month in Kakinada, our professor of psychiatry, ex-professor of psychiatry, is everything very fine. Okay, his son is a physician now in the hospital. So he had a myocardial infarction, a silent myocardial infarction, underwent the PTCA, and then he died. See, it's not the fault of the cardiologist. The picture is like that. He's a diabetic. Okay, so in a diabetics, it's a very diffuse disease, a multiple vessel involvement, more complications. These are very, very important. The worst outcome following the revascularization procedures when compared to the non-diabetic. So the take-home point is, why should we allow our diabetic individuals to have a myocardial infarction? Keep the blood sugars under control, keep the blood pressure under control, keep the lipids under control, make them the physically active, cessation of the smoking, cessation of the alcohol or the moderation of the alcohol, some yoga, some meditation. So you will keep the blood vessels intact. So don't wait our diabetes to get the myocardial infarction. Don't wait our patients to get the peripheral vascular disease and then the procedures. Okay, this is the very, very important. See the diagnosis of the coronary artery disease. So they may be the preclinical and the clinical. In the preclinical, you have the biochemical markers, the functional changes, and the structural changes. The biochemical markers, you have the lipids, homocysteine, high sensitive CRP, that is a vascular inflammation, fibrinogen, etc. And the functional changes, endothelial dysfunction. The structural changes, intimal media thickness. These are the preclinical levels. But no one will come to you at the preclinical stage. But most of our people are at the clinical with the chest pain, etc. Here you have the biochemical markers, the troponins or CPKMB or your SGPT, SGOT. So usually in the myocardial infarction, SGOT will be more when compared to SGPT. Whereas in the hepatitis, SGPT will be more than the SGOT. Okay. The resting ECG and then the repeat ECG, TMT, echo, stress thallium scan, angiography. So these are the clinical or your MRI heart or maybe the CT calcium score. So these are all the different investigations you needed in some individuals. Indications for the CAD screening in the asymptomatic patients with diabetes. So the routine screening of the asymptomatic individuals is not recommended since it does not improve the outcomes. Screening may be useful in the presence of atypical cardiac symptoms, signs or symptoms of the associated cardiac disease, carotid bruit, stroke or CAA or claudication of peripheral arterial disease, ECG changes except in the Q waves. So these are all the screening may be useful in these individuals. So the atypical cardiac symptoms, typical cardiac symptoms, okay, fine. Typical cardiac symptoms means you will have the chest pains, etc. And then the atypical unexplained dyspnea, chest discomfort, etc. Signs and symptoms of associated cardiac disease like carotid bruit or stroke or TIA, claudication, peripheral arterial disease. See, these are all the vessels are the same. When the fellow is having a diabetic foot with a peripheral vascular disease, so they die in the hands of the cardiologist rather than the surgeon. The same thing happens to your CVA fellow also. So he had left hemiplegia last year, so left and neglected, and definitely he will be living with a paraplegia or the hemiplegia, and finally in the next 2 years or 3 years he will die in the hands of the cardiologist with a massive myocardial infarction. So because the same vessels, so the same endothelial dysfunction, so say thrombus, so this is very, very important. So once the fellow is having the peripheral artery disease, he is at risk of getting more myocardial infarction. Once the fellow with the TIA, he is at high risk of getting the myocardial infarction in the near future. So whatever the peripheral vascular disease or CVA or TIA or CVA, so definitely one should think of the vascular anatomy and the vascular physiology and vascular pathology and then treat accordingly. So modalities of the CAD screening, except TMT may not be useful in asymptomatic patients. Cardiac CT, coronary calcium score. Now this is a very, very important investigation, non-invasive. So get the calcium score. So if it is more than the 400, is highly, the calcium is score is very high. So the more of atherosclerosis, and definitely one should be screened for the angiogram. But my score is 30, calcium score. So maybe good. So the physical activity and cessation of other things. So definitely we can come to the normal thing. Some fellows will be, calcium score will be 300. Some fellows will be the 200. So this is a very, more than the 400 definitely sent to a cardiologist. In the less than the 400 and then treat accordingly. Okay, with your dietary approach, etc. And PET scanning and stress echo and cardiac MRI. So they are the needed in only in some of the cases. So use a clinical judgment to decide on the advanced cardiac evaluation. Major goals: increase the coronary artery perfusion, decrease the myocardial workload, prevent the myocardial infarction, disability, and then the death, intervene in cases of the unstable angina. So the treatment recommendations to reduce the CV events: SGLT inhibitors and GLP-1 receptor agonists. They are the first choice anti-diabetic agents in individuals with type 2 diabetes and established atherosclerotic cardiovascular disease. So they are very, very important drugs in all the diabetic individuals to have a good vascular protection. So SGLT inhibitors are cardioprotective and also nephroprotective. GLP-1 receptor agonists, they are the cardioprotective and the nephroprotective. What are the SGLT inhibitors? You have the three SGLT inhibitors: canagliflozin, dapagliflozin, empagliflozin. Nowadays, canagliflozin we are not using for the fear of peripheral arterial disease and foreigners gangrene. You can use the dapagliflozin or empagliflozin as a cardioprotective agent. GLP-1 receptor agonists, you have the parenteral and also the oral. Parenteral, you have the exenatide, liraglutide, dulaglutide, semaglutide. In the oral, you have the oral semaglutide, Ribelsus, 3 milligrams, 7 milligrams, and the 14 milligrams. So these are the cardioprotective drugs. So the patient can afford. So definitely you can give the chronic diabetics, uncontrolled diabetic individuals, those people who are at risk of getting the vascular events, you can use these two agents. In patients with the known atherosclerotic cardiovascular disease, consider the ACE inhibitor or angiotensin receptor blocker therapy to reduce the risk of cardiovascular disease. They are the cardioprotective. ACE inhibitors, the ARBs are cardioprotective, nephroprotective, and vascular protective. So cardio, renal, and vascular protective drugs are ACE or ARBs. So you should use all these drugs where the patient is a hypertensive or even if the patient is a normotensive with microalbuminuria. Suppose if the microalbuminuria is there, so definitely you can have to use the ACE inhibitors or ARBs. In patients with type 2 diabetes and CKD, being treated with the maximal dose of the ACE and ARBs, addition of the finerenone can further reduce the CV event risk. So finerenone is a new drug entered into the market. It is a steroid-sparing mineralocorticoid receptor antagonist, like your spironolactone. So spironolactone is a mineraloreceptor antagonist. No? So that is one. Now the new one is the steroid-sparing one is the finerenone. So this is also very good drug. This is a renoprotective. Already I have given one lecture on the finerenone and I have put that finerenone in your YouTube also. So please go through that. Okay. In patients with the prior myocardial infarction, beta blockers should be continued for at least 2 years after the event. See, in all the IHD population, you use the beta blockers. So the beta blockers will reduce the mortality. So the mortality benefit will be seen with the beta blockers. So there is a compelling indication to use the beta blockers in a diabetic individual is the myocardial infarction or the post-PTCA or post-CABG or angina or unstable angina. In all the ischemic vascular diseases, you please use the beta blockers. Which beta blockers? Not the propranolol, not the atenolol, but use the cardioselective beta blockers or vasodilatory beta blockers like carvedilol, bisoprolol, nebuliol. Again, I have given 2 videos on the bisoprolol. Please go through that. Okay, there is a cardioprotective beta blockers. Bisoprolol, you have the Conquer, you have the Bisotab or Bisonext, etc. They are available in the strength of 2.5 milligrams, 5 milligrams, 10 milligrams, and you have the bisoprolol plus telmisartan combination is there. Bisoprolol with the amlodipine combination is also there. So you can use these drugs. See in this slide, the most important drugs are SGLT inhibitors, GLP-1 receptor agonists, ACE inhibitors or ARBs, finerenone if the patient can afford, and the beta blockers. So these drugs should be given in all the high-risk diabetic individuals not to have the vascular diseases. So revascularization therapy. When the medical therapy fails, invasive procedures are required. So we need the help from the interventional cardiologist. PTCA, flattening the flake with a balloon-tipped catheter to open the artery. That is the PTCA. Stents, tubes inserted after the angioplasty that open once a clogged artery. So that is your PTCA, stents. CABG, grafting the vessels to bypass the lesions. See, the long-term outcomes in the patient with diabetes is worse than in those without the diabetes. So the diabetes itself is a big risk factor for the vessels. So all the long-term effects also will be worst in the diabetic individuals. CABG seems to be superior to the PTCA with the first generation drug-eluting stents in individuals with the diabetes. Earlier, they used the metallic stents. Now they are all using the drug-coated stents. Even with the drug-coated stents, CABG is much more better than the PTCA in some individuals. Management of the diabetes in acute myocardial infarction. Avoid all oral antidiabetic agents during the acute episode. Use only insulin. So sometimes in the ICU, the one drug which is common for all the ICU individuals, cardiac ICU individuals, is the insulin, because all are diabetics. So the only drug which is common for all the patients is the insulin. So don't use the OHS in the acute myocardial infarction or acute cerebrovascular diseases or in acute medical unit with the sepsis or with the fever, etc., etc. In all acute medical emergencies, don't use the OHS, use the insulin. That is the dictum. Metformin is generally not recommended. Metformin, even though it's a very good drug to reduce the insulin resistance, etc., because it increases your metabolic acidosis and lactic acidosis risk. Maintain the blood glucose around 140 to 180. So more than the 180, introduce the insulin. Less than the 140, withdraw the insulin. Maintain the blood sugars between 140 to 180 with insulin. Which insulin? With regular insulin. So always in the ICUs, use the regular insulins only. Don't use the mixed shots here or the insulin shots. Use the regular insulin, 3 shots or 4 shots a day, or you can use the glargine or the deglutec like the Lantus, etc. as the basal insulin to reduce the fasting blood sugars. Start insulin if the blood glucose is persistently above these thresholds. So more than the 180, so definitely have to use the insulin, maybe 2 units, maybe 4 units, maybe 6 units, depending on the blood sugar. Suppose the blood sugar is 300, use 10 units or 15 units. Suppose if the blood sugar is 220, use only 4 units or the 5 units. So depending on the blood sugar values, you can reduce the or increase the dose of the insulin. Use only short-acting insulin. Once patient is stable, can be shifted to either an insulin-based or OAD-based recipe. Management of diabetes in acute myocardial infarction. Is insulin the answer? Yes. In the Degami study, 620 patients with acute MI were studied. Either a GIK infusion followed by the intensive insulin therapy or the conventional therapy. The insulin treatment group showed 10% reduction in the mortality at 1 year compared to the conventional therapy. So using the insulin showed a 10% reduction in the mortality at 1 year compared to the conventional therapy alone. So use the insulin, use the intensive insulin. Keep the blood sugars between 140 to 180 only. So secondary prevention. So already had myocardial infarction. Now what to do as a secondary prevention? Not to have the myocardial infarction, that is the primary prevention. Now the secondary prevention already had infarction. So antiplatelet therapy, like for aspirin, clopidogrel, ticagrelor, prasugrel. So these are all available right now. Okay. So in the initial days, 6 months, use the 2 drugs, 2 antiplatelet agents. After 6 months, you can come down to, you can use only a single antiplatelet agent. So when you are using the 2 agents, we use the aspirin plus the clopidogrel. Okay. Or clopidogrel plus ticagrelor or the prasugrel. So this is how you have to use these 2 drugs. Beta blockers. Already I told you. Which beta blockers to use? Cardioselective beta blockers like carvedilol, bisoprolol, nivolumab. ACE inhibitors. Which ACE inhibitor you use? Ramipril. Or ARBs like the statins. Maybe your telmisartan or olmesartan or isilsartan or candesartan, valsartan. That's it. Statins. So which statins you use? Either atorvastatin or the rosuvastatin. Atorvastatin 80 mg is equal to rosuvastatin 40 mg. Atorvastatin 40 mg is equal to rosuvastatin 20 mg. So atorvastatin 20 mg is equal to rosuvastatin 10 mg. Atorvastatin 10 mg is equal to rosuvastatin? Good, 5 mg. So that is a double the dose of the rosuvastatin is your atorvastatin. SGLT inhibitors like the dapagliflozin and empagliflozin. GLP-1 receptor agonists. So they are preferred as anti-diabetic agents. So in all the diabetic individuals, who as a secondary prevention had a myocardial infarction, so definitely you have to use the platelet agents, you have to use the beta blockers, you have to use the ACE inhibitors or ARBs, as the statins, And then the diabetes, either the insulin or the OHS. In the OHS, preferably SGLT inhibitors and the GLP-1 receptor agonists and metformin if the patient is an outpatient. So the primary prevention is high risk individuals. So to use the aspirin or not. So earlier studies use aspirin as a primary prevention. So the present studies is don't use the aspirin for the fear of intracerebral hemorrhage. As a secondary prevention, definitely have to use the aspirin. As a primary prevention, again a $1,000,000 question. Whether to use or not, it is our discretion. So earlier we used to use the aspirin for all the high risk individuals. Now we are not using the aspirin for the fear of intracerebral hemorrhage. So aspirin therapy 75 to 160 may be considered as a primary prevention therapy, may be considered, should not be, maybe. In those with diabetes who are at increased cardiovascular risk, after a comprehensive discussion with the patient on the benefits versus the risks, bleeding. For patients who are the age of the 70 years, with or without the diabetes, use of aspirin for preventive prevention appears to have a greater risk than the benefit. So in elderly individuals, because the vessels are very friable, so the chances of having intracerebral hemorrhage is much more higher. So even if you want to use the aspirin for a primary prevention, better in younger individuals or the middle-aged individuals, but in elderly individuals as a primary prevention, don't use it. Achieve the lipid goals. What you mean by the primary prevention? So good goals, the aspirin plus or minus. But the lipid goals 100%. BP goal 100%. Diabetes goal 100%. Smoking 100% cessation. Alcohol moderation is 100%. Your psychosocial factors 100% reduction. So these are all very, very important. So to reduce your primary prevention, so these are very important. Your ABC and etc. etc. So strategies for CAD risk reduction in patients with the diabetes. This is a 10-point formula. Already we discussed. Early diagnosis of the diabetes. So diagnose the early so that we can intervene much early. Good control of the diabetes, that's very important. So with a 5 years history of diabetes, 7 years history of the diabetes, HbA1c 10, 11, 12, not good. Always keep the HbA1c around 6.5. Control of dyslipidemia, total cholesterol less than 200, triglycerides less than 150, LDL less than 50 or less than 70. Okay. HDL more than the 40 in the males, more than the 50 in the females. That is your dyslipidemia goal. BP, already I told you. Aspirin, plus or minus. Dietary modification, always yes. So reduce the saturated fats, reduce the trans fats, reduce the non-vegetarian, reduce the masala. So these are very important dietary modifications. Reduce the salt. Exercise, yes, at least 10,000 steps a day or 15,000 steps a day. And half an hour yoga, at least 10 minutes or 15 minutes of meditation. So these are very important. Weight reduction, yes, you are overweight. Quit smoking 100%. Relaxation techniques, etc. So this is the 10-point formula to have a good vessels in all the diabetic individuals. Not only your CAD risk reduction, maybe for your CVA and also for your peripheral vascular disease, all the vessels. So heart failure. Now coming to the heart failure. See, the heart failure is very, very common nowadays because of the longevity of the individuals. See, earlier the diabetic individuals, they used to die much early, at 45, 50 or 60. Now they are living 65, 70, 75 with a diabetic history of 40 years or 50 years or 25 years. So that means the myocardial damage. So that means heart failure. So type 2 diabetes is a risk factor for both the heart failure. Now the heart failure is divided into 3 groups. Heart failure with the reduced ejection fraction, that is called the heart failure REF. Heart failure with the preserved ejection fraction. Heart failure PEF. And heart failure with mid-range ejection fraction. So that is MR-EF. Okay, mid-range ejection fraction. So you remember as the PEF and the REF. REF means reduced ejection fraction. EF will be less than 40. PEF means preserved ejection fraction. So EF will be more than 50. So when the EF is more than 50 with heart failure, so that is heart failure preserved ejection fraction. With the EF is less than the 40, heart failure REF. If the EF is between 40 and 50, that is heart failure mid-range ejection fraction. So the risk increases with the older age, concomitant coronary artery disease, peripheral artery disease, nephropathy, retinopathy, obesity and hypertension. See, in India, there are the 4 causes for the heart failure. The most important cause is the coronary artery disease. The second one is the diabetes. The third one is the hypertension. And the fourth one is the anemia or rheumatic heart disease or postpartum or viral, etc. So the three important causes for the heart failure in India is the coronary artery disease, diabetes and hypertension. And other causes, postpartum cardiomyopathy, anemic cardiomyopathy, alcoholic cardiomyopathy or post-viral cardiomyopathy. Most of the people with the COVID, they had the myocarditis. Okay, so the cardiomyopathies, that is the cardiomyopathies. Okay, and then the rheumatic heart disease. So earlier rheumatic heart is the number one. Now the rheumatic heart disease is that last one. Maybe your mitral stenosis or mitral regurgitation or your aortic stenosis, aortic regurgitation, heart failure. So that is at a lower level, right? Clinical outcomes of the heart failure are worse in people with diabetes than in those without the diabetes. Again, what are all the diseases you know of? The outcomes will be very, very worse in the presence of the diabetes when compared to the non-diabetics. See, heart failure in the diabetes can occur in the presence or absence of the significant epicardial coronary artery disease. See the diabetes. So the diabetes, you will have the hyperglycemia, you will have the insulin resistance, you have the hyperinsulinemia. Then there will be the inflammation, dyslipidemia, coronary artery disease, and ischemic cardiomyopathy, the red one. So that is your coronary artery disease. And the green ones are cardiomyocyte hypertrophy, that is diabetic cardiomyopathy. And the RAS activation, more fibrosis, more calcium, more autonomic dysfunction, again will lead to the heart failure. So in a diabetic individual, heart failure can be done in 4 or 5 ways. One is post myocardial infarction, coronary artery disease. Another one is cardiomyopathies. And another one is fibrosis. And then the RAS activation and autonomic dysfunction. Autonomic dysfunction is also very common in a diabetic individuals. Management. So the metformin is good, sulfonylureas, insulin, GLP-1 receptor agonists have the neutral effects on the outcome, heart failure outcomes. But some DP4 inhibitors like saxagliptin, it is contraindicated in the presence of the heart failure. Okay. And SGLT inhibitors are the only class of the anti-diabetic agents shown to improve the outcomes of the heart failure. So in the heart failure management, you have the 4 pillars or the 5 pillars. What are they? Number 1 is ACE inhibitor or ARB or ARNI. And the second pillar is beta blocker. Third pillar is mineral receptor antagonist. And the fourth pillar is SGLT inhibitors. These 4 are the pillars of the management of heart failure. One is ACE, ARB or ARNI. Okay. The second one is beta blocker. The third one is your spironolactone or finerenone. That is your mineral receptor antagonist. And the fourth pillar is SGLT inhibitors. Now the fifth one is the Versiogat. There is a new drug entered into the market that improves your nitric oxide levels. Okay. So that's how we treat the heart failures. So the management of the heart failures. Already told you, renin-angiotensin blockers, mineralocorticoid receptor blockers, angiotensin receptor blockers and neprilysin inhibitor, that is ARNI, beta blockers, SGLT inhibitors, evaporatin, that is to reduce our heart rate, and implantable cardioverter are the defibrillators. Thank you very much for your patient hearing, and if you have any queries, I will be very happy to answer them. Thank you. Thank you.